Good afternoon, everybody. I'll just share my slides and thank you for tuning in. So my slides are sharing now, and I'll just step through the presentation. The agenda for today is on your screen now. So I'll give a brief summary of the implementation of health regions and where we are at the moment, as well as handing over to colleagues then to focus particularly on population health, and each of them in turn will speak to the items on the agenda. When I'm finished, I'll hand over to Dr. Jennifer Martin, and we'll wrap up at the end. Thank you. The overall objective is to give an update and then to talk specifically to population-based health planning, and that'll be the course of our presentation. Thanks. In terms of the regions, just to remind people, the purpose of Sláinte Care and the whole purpose of the work that we're doing at the moment, my own role as Director of the Change Programme within the HSE, reporting to the CEO, is to support the structural changes that are underway. But the wider purpose is to deliver person-centred care, informed by the needs of people and communities, to focus on alignment and connection between care locations, hospital and community, and to coordinate care closer to home, as well as continue to operate to national standards, but also supporting more local decision making. And a key piece of Sláinte Care is very much about improving health and well-being and focusing on local needs delivered locally and with accountability locally. The objectives, high-level objectives within Sláinte Care, are about alignment, as set out in point 1, clarifying and strengthening corporate and clinical governance, supporting a population-based approach to service planning and delivery, which aims to address health inequalities, and colleagues will speak to that further later in this presentation, to improve equitable regional investment and to run an efficient and highly productive and transparent health and social care service. And as you know, we're moving from 9 community health organisations and 6 hospital groups to 6 regions, joined up regions that are an integration of both. So we're going from 15 entities to 6 entities, and decisions that have already been made are around naming and logos. There is, of course, one board of the HSE, and that remains the case. So there isn't a legislative change around these changes, but there is still one board. The regions are administrative subdivisions of the one HSE. The regional health forums will move from being 4 in number to being 6 to align to the regions. We're in a transition period, and I'll talk more about that. The focus will switch operationally from the centre to regions, and there's been significant change in that already. So the centre will not primarily be operational, it will be about planning and enabling. And the centre will retain a role in standards and guidance. And the centre and region structures have been agreed, and I'll talk more to those. Just by way of journey mapping, to the far right of that slide, where we are right now is we're recruiting posts to populate the executive management teams of the regions, and most of the posts on a revised basis within the HSE centre are now in place. There'll be a diagram on that in a moment, but we've been on a journey of engagement. You can see there's a plan there in July 23, just above the line, which was a plan approved by government. My role and the team working with me are charged with implementing that plan. There's 28 actions in it, and we're implementing that within the HSE environment, working with voluntary groupings and indeed with patient groupings. So from our point of view, the next steps really are about the detailed work of both recruitment and creating the further more detailed structures underneath the regions of that at the moment. So at a national level, that's the revised shape of the national centre of the HSE. Most of those posts are filled. The post entitled Access and Integration is in recruitment, and indeed the post on the right, Strategic Infrastructure and Capital Delivery, also in recruitment. The rest are filled within by assignment or retention of current national directors. And the CEO is very clear that the service spine of the service is now from himself to 6 regions, and actually subsequently to 20 integrated health areas underneath 6 regions. And at a region level, underneath a regional executive officer, you have integrated health areas, and you have supporting clinical infrastructure on the left-hand side of that, and functional infrastructure on the right-hand side. So those posts, many of those posts are in recruitment, some job descriptions still being recruited. And just to point out, the estates function and national ambulance service on the far right continue to report nationally, but have people available to sit with the REO regionally. The piece of work we're engaged in at the moment is what is the service organisation underneath the integrated health area look like. This is where all the hospital and community services and the voluntary contracted services sit. And so there's a detailed programme of work at the moment around design of that. But what's clear is it will be connected. So there will be a singular accountable person for all of those services, being the integrated health area manager, and those posts are recruited at the moment. There will also be networks of care to provide a standard basis for care delivery across those systems and encourage the delivery of integrated care, which is a key piece of Sláinte care. So that's a work in progress that's underway at the moment. The next steps for us are set out there, and you can see that program goes as far in the top right, it's 425, but we are in a stage of design, implementation, and then supporting change within the regions. The small central team that I'm working with has been key to the design, working with the steering group and the CEO, and now working with the regional executive officers. But increasingly, the implementation will be a matter for the operational health environment. And so I'll pause there and hand over to Dr. Jennifer Martin. Thank you. I'll stop sharing now.
Hello, everybody. I will just hopefully get up my slides now. Okay, I think they're up. So hello, everyone. Again, my name is Jennifer Martin. I'm a consultant in public health medicine, and I'm leading the National Health Service Improvement Team in public health. And I'm here with my colleagues, Dr. Declan McKeown, consultant in the National Health Intelligence Team, and Dr. Naomi Petty-Saffin, who's a consultant in Dublin and Northeast Department of Public Health. We are going to talk to you today about population health and how we are working on improving population health in our work with the health region implementation. So, what is health? So health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. That's what we have been using as our definition for many years from the WHO. So when we think about that, it's really about being well and healthy. When we think about population health, then we are also aiming to have that state of optimal physical, mental, and social well-being, but at the whole community level, and where everyone has a fair opportunity to thrive, because we can't have a healthy population if we're leaving people behind. And that's one of the real key principles in Sláinte care that we're aiming to address with this work. But just taking a step back, what actually causes health? Is it the health service, or is it where we're born, where we live, our education, our work, and the communities and the places in which we live? In fact, it's generally accepted that healthcare itself causes or is responsible for only about 20% of people's health and well-being, with about 30% being caused by health behaviours, diet and exercise, alcohol, etc., 10% the physical environment in which you live, and 40% by what are known as the social determinants of health, or education, your job, your income. However, in health and social care, we do have a huge opportunity to increase the impact we have on population health, because we can take a population health approach in the work that we do, focusing on those things like prevention, focusing on equity, and also we can really extend our reach by partnering with communities, with other stakeholders outside of healthcare to reach further into communities. We're working on this in the HSE at the moment to really come up with what population health means for us in Ireland and what's our approach to achieve it. So in essence, though, obviously the approach needs to take the perspective of the population, not just the patients who turn up in health or care. The approach focuses on being well, so prevention, on equity, leaving no one behind, on those determinants of health, of which healthcare is an important determinant, but working with those other ones like education, etc., and on sustainability. So we really focus now across our health service on designing it and delivering healthcare for people today that isn't going to negatively impact on people and the world tomorrow. If we want to improve population health, the way we need to work is through partnership and engagement, not just with ourselves in health and social care, but with our communities, with our wider stakeholders. We need to base our work on evidence of what works and measure to see, are we doing what we plan to do, and are we achieving the population health outcomes that we aim to achieve? And we want to take an integrated, coordinated and system-based lens, looking across the whole pathway and the whole life course. And of course, we have to allow ourselves to continuously learn and improve. We're not going to get it right first time. So the piece of work that I'm going to hand over to Declan to talk about now in a second is how we've been working on population-based planning with the ambition of improving population health. As Liam has said, one of the 5 strategic objectives is to take a population-based approach to planning. But what does that mean? So basically what we want to do is help a cohesive and integrated approach to the assessment of needs and unmet needs of our populations at national, regional and local level that supports decision makers in service prioritisation, planning and resource allocation that are orientated to the needs and the preferences of the population. Population-based planning encompasses many different approaches and methods, all of which really start with the foundation of the population profile, which Declan will talk to you about now. Over the course of the year and the next years, we're working on health needs assessments, strategic needs assessments, working with the Department of Health on population-based resource allocation, population health management, all with the aim of designing and redesigning our services to meet the needs and preferences of the population. And we look forward to telling you about those later on. But for now, Declan's going to talk to you about the population profiles.
Very many thanks indeed, Jennifer. I'm just going to share my slides with you here. Declan McKeown is my name. I'm a consultant in public health medicine in the National Health Intelligence Unit. And it's been a great privilege to be able to share this journey, I suppose, really with my fellow colleagues and panelists and presenters. So this is a tremendously important area that we've embarked on this journey. So what Liam and Jennifer have very carefully and very meticulously explained the infrastructure and the architecture and the governance around this. I wanted to talk a little bit about some of the outputs. And the first one is this. This is still a relatively new process. There was a workshop that kicked this all off last October, last autumn, and there's a workshop report within that, and that's an important document because what it does is that shows the thinking, the rationale, the transparency, if you like, the theory behind why we're doing this. It shares the language, make sure that we're using a common language that everybody knows, understands what various terms mean, but it also looks at aspects like internationally what people do for things like needs assessments, what population planning means in other countries. So this was determined as a way of trying to lay the ground, if you like, for the second output really, which was the regional population profile. And this again is a very recent document. This just came out at the beginning of March to meet the new REOs coming into place. And this was essentially the first step. Understand your population before you can understand your health, before you can begin planning systematically. And this is a very important first step. And another output from this was the Regional Population Profiles National Comparative Report, which really showed how each region measured up against the other. Now, one thing that we've said from the very beginning is that regions are big places. We need to understand the profile of a region, but we also need to understand the kind of demography and the makeup of the population underneath that. So this led us to our landing page, our population profiling maps. And what this does is this essentially recreates these regional profiles, except at a CHN level. It's a community healthcare network, about 50,000 people. There are 96 of them in the country. So we have a landing page that has the profiles, the same parameters, and I'll explain how we got into those, the same parameters for each of the 96 profiles, along with a boundary map, deprivation map, and population density map. But before I get into that, I just wanted to flag this collaborative approach. I think this has been something that's injected a tremendous amount of energy and robustness, I think, into the process. The profile subgroup originally, it's derived from 6 regions with 2 national teams. A lot of communication, a lot of if you like, choreography of individual needs and wants into a kind of a single common pathway. And that led to shared decision making on what needed to be a standardized profile. We say standardized because there are 96 parameters in the CSO census. We wanted to kind of identify a number of headline parameters, those critical few census measures that were really important as an elevator pitch for the REOs coming in. These are the important things to concentrate on. But the real value, I think, of this, and Naomi will talk to this after me, is the local adaptation and how that the extra value being we can show what the parameters are, we can show what percentages and profiles and proportions are, but really to understand what that means in a given region for public health, that's something extra, and Naomi will talk about that. But first of all, really, as I mentioned, there are 96 census parameters, and I have to shout out my colleagues, Dr. Geraldine Sayers and Dr. Teresa Bennett, who worked tirelessly to get these into Health Atlas Ireland. And these are available through the Health Atlas Finder. So what we're saying is that we wanted to kind of take headliners from this. So we spoke to a range of professions across a range of backgrounds. We presented each of them with the 96 parameters, and we just simply asked each of the respondents to rank them 1, 2, 3 according to what they felt was the importance of it. Now, 1 meant we need to show this to the REO. This is a really important parameter. 2 was if we have time and space, we can do this. 3 was we don't need to bother about this now, on the understanding this is all available within the Atlas Finder anyway. We totaled all those parameters, included all the parameters that everybody said was one that needed absolutely to go in. We excluded everything that was scored 3 that people said we can do without. Then we ranked the remainder. We identified a median score, just highlighted there, and then we looked at those, essentially those factors that were included, and thought, is there any way we can whittle these down a little bit? And it was quite easily done, essentially. We retained only the total tables, which meant we removed any kind of male-female subtables. And these are obviously very important for planning, but for the elevator pitch, for the headliners, we thought the totals are going to be more important. So we got this final list of 16 parameters, which essentially is a demographic dashboard, and our software partners in OpenUp installed a quick pick button within Health Atlas Finder to allow us to create a standardized output from Health Atlas. Now, the regional profile was modified, and again, Naomi will talk a little bit about that, but these are the, if you like, the bones of the profiles that we made available for all 6 regions, and again, underneath that for each of the 96 CHNs. And just to understand the geography, we have the regions here. They're large areas, just to show how they, I suppose, how they fit in to the thinking. The health regions are large areas. If we zoom into health region, we can see within that we have a CHN. It's about 50,000 people in a CHN, but each of these sub-regions fits into the region like Russian dolls. They should be absolutely contiguous. And I will say the Health Atlas Ireland, it displays all of these, and it's all available on the Atlas. We display the boundaries. We're not responsible for them. Those are decided at a national level, but we display what is agreed nationally. Within the CHN, we have PCTs, primary care teams, again, about 10,000 people within a primary care team. And you can see, again, they slot within each other like jigsaw puzzle pieces or Russian dolls. If we zoom into a PCT, and again, we're still in Dublin Northeast here, these can be further broken down to ED or electoral division, about 1,000 people in there, and then zoom in again, and these will be broken down to small area, SA, so CSO small area, about 200 people. And the importance of this is we can profile down to this level. We can show, for example, population density to see where you need to focus maybe services or personnel. We can also profile by deprivation at a small area. So we can see very, very clearly just to the, for example, to the west of Castlebellingham, this area of relative deprivation in comparison to the rest of the area. So it means if you're providing services in that area, you may become aware that this is an area where people live that might need a little bit more. So the landing page that we developed to show these profiles, it's very, very simple. We can see we provided the regional profiles, and so this is just, for example, Dublin Northeast. We open this up and we see for each region we've got the profile itself, the profile with added value, as Naomi will describe, and we have for each of them a boundary map, deprivation map, and a population density map for the whole region and for the kind of the most populated area of it. But we also, to allow people to explore their area a little bit more and to understand maybe some of the granularity of it, we also provided this by CHN. So there are 96 CHNs divided into the 6 regions. So for that, we have our Finder profile, again, the 16 parameters from that quick pick, that dashboard I mentioned earlier. We've got a boundary map, we have a deprivation map, and we have a population density map. So these we believe will help people to understand the makeup, the granularity, the kind of the individual nature of their own areas, and to help them to provide services accordingly. And just for use of access, there's a QR code there. It is available. It can be seen. It can be viewed on a mobile phone. It's not necessarily configured for that, but that is available through that short URL there. And Health Atlas Finder, of course, is available for everybody within the HSE, and we offer training on a monthly basis as well. So what I will do now is I'm going to hand over to my colleague Naomi, who will describe really the kind of the extra, the art, if you like, behind it, the regional meaning of what was entailed and what each of these parameters meant.
Thanks, Declan. So I'll just share my slides now. So my name is Naomi Petty-Saffron. So I am a consultant in public health in the Dublin Northeast region. And I'm just going to walk you through some of the parts of the profile. So this is the profile for the Dublin and Northeast Health region, but the same structure, the same content is there for the other 6 regions, which you can find online, as Declan was just saying. So just to give an overview of the Dublin Northeast region, so it's the largest health region. It's got just under 1.2 million people. That's 23% of the national population. And within that health region, there are 20 community health care networks, which are shown on the map there. So when we're looking at these profiles, what we do is we look at the health region overall, how that compares to the national picture for the parameter. And then we look at it by each CHM, because as Declan was saying, the health regions are quite a large geographical area, but then there's variation within your CHNs. And obviously, if you go further into kind of smaller geographies than the CHN level, you'll see further information, but that's a lot to show. So it's kind of, that's why the facility on Health Atlas is there for that purpose. So population size and age structure are significant drivers of healthcare need, with the extremes of age really requiring the most healthcare services in general. So the very old and the very young. So overall, the Dublin and Northeast population is slightly younger than the national average, as you can see on the left. But then when we look at it by CHN level, you can see there's variation. It might not come out that well on the slides, but each of those bars, the top bar is the national picture. Then the second one is the second one down is the healthcare region overall, and then the age structure by each of the community healthcare networks. So you can see that there are some CHNs that have got an older population than the national average, and then more than half of the CHNs within the Dublin Northeast region have a younger population, so a bit larger proportion of people aged under 15 than the national average. So there's going to be differing healthcare needs within the CHNs within one health region. The other main driver of healthcare need is deprivation. We know there's a well-established social gradient in health, and increased deprivation is associated with poorer health outcomes. That includes lower life expectancy, development of long-term health conditions, and mental illness. So these maps here in the bottom corners are showing the deprivation score for the health region overall by electoral district. And then that's just a focusing on Dublin because of the number of people. So you can see the majority of the area is yellow, which is kind of average deprivation. And then the areas in purple and blue are more affluent areas, and the areas in red and orange are the more deprived areas. And then when we look at this by CHN, you can see there's considerable variation between the CHNs. So the Coolock area network there is the third line down, and in that community healthcare network, over half the population are living at disadvantage. Whereas then we've got the other extremes as well. So areas such as the Clontarf and coastal area networks have areas of higher affluence. And this will all play a part in how we want to deliver our services and the potential healthcare healthcare status and issues facing the populations in these areas. Another factor we included is ethnicity and country of birth. So we know that areas with higher levels of migration and minority ethnic groups may require specific interventions, not only to ensure that they're able to access services, but that we are providing culturally appropriate services, and that the correct information is available in a format that it can be understood and accessed, as well as the fact that healthcare needs may differ for different ethnic groups. So the Dublin Northeast region has a more ethnically diverse composition than the national average. And you can see some of those lines at the top of the bars there. You can see this in more detail online. If it's probably not projecting that well on the screen, but you can find it all online, so you can see it kind of up close. But you can see that some of the CHNs have a much higher proportion of their population who are born outside of Ireland and the UK. And kind of going hand in hand with that is language. So we know that language barriers can contribute to healthcare inequalities, not only for people accessing healthcare, but they have an impact on the wider determinants of health. So things like employment and your social circumstances. So when we look at the DNE population, we can see that the largest numbers of people that do not speak English well or at all are in the CHNs that also have the highest proportion of people that are foreign language speakers, as you'd expect. But then there are other areas, like in Cavan and Monaghan, where there are large numbers of people that don't speak English well or at all, but a relatively low proportion of their population that are foreign language speakers. So we need to make sure that we're providing our health messaging and communication in the right manner, and then it may need to be tailored to those people and populations so that it can be understood and have an impact. And also that healthcare needs in different CHNs may differ when we're looking at things like translation services and supports. We looked at some of the health factors available in the census. So looking at general health, smoking and disability. In terms of general health, the first image there, there are lower levels of very good or good health reported in CHNs, particularly in the North Dublin area. And of note, these are the places that are usually more had higher levels of deprivation. And then when we look at the population who were smoking, considerably higher levels in the North Inner City area, which is the very dark purple on the bottom right of the middle graph, and which is an area with high levels of migration and large numbers of people that don't have good English. And then also the second one was the Coolock area network with high levels of deprivation. So this is all important for how we might want to look at planning our smoking cessation services and making sure that people can access and understand them. And then when we look at disability, the highest levels of people reporting to have a disability were in the older CHNs with older populations. So some of these were the very affluent populations like the Clontarf and coastal areas, but also in the areas that are have an older population and high levels of deprivation like Finglas and Coolock area networks. So providing unpaid care is an important factor in terms of healthcare. It's important to the welfare of individuals, to their families and of society. And the proportion of people that provide unpaid care in the DNE region overall is lower than the national average. But that varies when you look at it by CHN, with higher numbers of people providing unpaid care in the coastal area network, which is the oldest area CHN within the region. And then just lastly, to mention education. So education, it plays into deprivation, but it's also itself an important determinant of health. And there's a strong relationship between education levels and health outcomes. So when we look at the population and the education levels, overall, the population in DNE have a slightly lower level of people with third level education than the national average of just under 43%. But this ranges from 29% to over 55%. So we know that improving educational outcomes in the most disadvantaged groups has got the potential to make a positive impact on health inequalities. And higher levels of education not only benefit the individual, but they can have positive effects for the economy and for society. So that was just a very quick run through of the overview of the profiles and some of the things that are included in it, and how you can see that there are differences between the CHNs. If we look at it at a smaller geographical area, as Declan was saying, we'll see more differences will become apparent. And these have been useful looking at seeing where we should target for things for informing decisions. And they've been useful for people for giving context to local issues. So, for example, looking at vaccine uptake and deprivation. So just to summarize, myself, Declan and Jennifer have just given an overview of population-based planning, how we did, what we did and how we got there, and then a walkthrough of the population profiles. But it's important to remember that this is just the first step in the population profiles. So this is the demographic information, and the next steps are going to develop a population health profile, and that's going to include information on health status and health services. And so together, that information with the demographic detail can be used to inform health services and health planning, and feeds into population-based planning. So I just want to say thank you from Jennifer, Declan and myself, and acknowledge everybody that's been involved in this work. And we are looking forward to working with you in partnership with everybody who works and uses and lives in our communities and in our healthcare services. So now, thanks, and I will pass back over to Liam.
Thank you, Naomi, and thanks for the presentation. I'll just share slides again for a moment. Okay, and I think you saw briefly but very effectively, and thank you to Jennifer, Declan and Naomi for sharing the information they did. They brought us from the determinants of health to the data in use through profiling, and then on to the intelligent use of that information to become aware of what that means in localities. So you can see straight away that that's enormously useful information from a health planning, health appraisal, health assessment point of view. And it's a resource that's now available to the 6 regional executive officers for their regions, and I'll drill down. Happily, Declan, I was able to scan your QR code and get onto the HSE site and get directly to the point and click profiles that are available, and I hope people on the call can do the same, though the links were also available. So that was really a very structured swim through an ocean of information, and as Declan says, filtered to on a priority basis. So really useful information. From our point of view, I think for the REOs, for the regional executive officers recently appointed, and for the CEO and national system, it's a massive resource to help us move in the direction of what's intended within the healthcare environment, and that is about having a population health driven approach to healthcare planning and delivery. So from our point of view within the Health Regions Change Team, this is the first of a number of such sessions, so we hope you find it useful. We'd welcome feedback on this particular event and also on topics of interest. Very much happy to follow those up, and we'd look forward to further engagement. And just once again to thank very much Jennifer, Declan and Naomi for the inputs. So for next steps, the regional executive management teams are being recruited, as I had said, and that includes integrated health area or IHA managers. Integrated service delivery model is being developed, and that's including the design at a sub-regional level or integrated health area, so 20 units across the country. And there's an ongoing process of engaging with stakeholders and regular communication. We do intend to hold more Health Region webinar series through the course of this year. We've put in some contact information at the base of the slide, and this will be available to you. But you can see on the HSE website, there's a link. There's also an email address that you can access, and there's more detailed Health Regions email address in the center of the slide. So thank you very much for your attendance, and we'll leave it there.